We're going to get going. So for those of you that don't know, welcome to the Flourish Caregiver Coaching class. My name is Dr. David Carrion. I am a psychiatrist in Silicon Valley, and I've taken care of many people who have been depressed. And I've talked to a lot of family members of those people, and it's a hard thing to be a caregiver of somebody who's depressed. I mean, it's hard enough to be depressed, but it's also hard to care for or show affection for somebody who's depressed. And so what we're going to be talking about today is how, what exactly is depression, and then how can we provide care to those who are in a better way, with an emphasis on communication. So as we've described before, there's going to be a section that's going to be recorded, that's going to be teaching. We're going to have a Q&A. That part's going to be with me, and then we're going to have an interactive skills course. So without further ado, we will get going with the actual material. So how to be a supportive caregiver for somebody with major depression. This is a giant question. So the very first question is, what exactly is depression? We use the word a lot in vernacular. Oh, I'm so depressed, or that was so depressing. But there's a very important challenge. There's a very important question around what exactly is this to have major depressive disorder? And so that's the condition that is more severe than the typical ups and downs. It's more severe than just somebody who is having a hard time on their day-to-day. And so we're going to be talking about what that is. And so with the symptoms of depression, this is a condition that goes back a long time. This is a classic description, I believe, of major depression. This is from the book of Job. When I lie down, I say, when shall I rise, and the night be gone? I am full of tossings to and fro unto the dawning of the day. My days are swifter than a weaver's shuttle, and are spent without hope. So that my soul chooseth strangling and death rather than my life. And so you have this this classic, at least in the Western canon, this classic description of this character Job, who is experiencing terrible circumstances. And the question is he, and he's wanting to be, he'd rather be dead than alive, and experiencing even some of these physical symptoms of insomnia, not being able to sleep, having difficulty with feeling hope for the future. Contemporarily in the modern world, this is DSM is our sort of definition for a variety of mental illnesses. And the symptoms of depression are varied. And so if you have 5 of 9 of the following with some other criteria, you are depressed. So the most obvious one is depressed mood, feeling down or sad or depressed. But also sometimes it's not any change in sadness, but the emphasis is on decreased pleasure in activities, not being able to feel warm or connected or experience joy. It's more of a flatness or a vacuum than it is a depression or a low mood. So there's also disordered sleep and appetite. There's reduced energy. There's slowed thought and movement. There's indecisiveness and poor concentration. There's feelings of worthlessness and guilt. And there's recurrent thoughts of death or suicide. And a lot of these things are sort of general, and I say like feelings of worthlessness and guilt, and like there's a common human experience of feelings of worthlessness and guilt. Depression is when these things are all the time, when these things are pressing down most of the time, nearly every day. And the other thing to note is that in the definition of depression, none of these things requires a person to be to have there be negative circumstances. Sometimes depression, the circumstances are pretty obvious, but other times there's no clear connection to why a person is feeling these things. And sometimes the circumstances kick it off, but it has a life of its own even after the circumstances get better. So this is the sort of symptom definition of depression. But if you look at people who have these symptoms, you see a whole variety of changes in their body and brain. Now, in terms of the severity of depression, I think one thing that's really important to note is that it's pretty bad. And for those of you who have a depressed loved one, you know that it's bad. It's not a surprise that the person is in a lot of suffering, but it's sometimes useful to know just exactly how serious a condition your loved one has. And so there is a domain of study which is rather morbid, but it's comparing how miserable diseases are to each other. It's useful for quantifying and figuring out which domains of our healthcare system get which sorts of resources. But the unit is disability weight. And the more serious the condition, the higher the disability weight. And so I'm going to show you a few pictures of a few comparisons. So, okay, so everybody's, I made these slides before this was exciting, but if you had a terrible infectious disease, say a terrible flu, that's about a disability weight of, between 0.1 and 0.2, which is bad, but not as bad as the day that you're having a heart attack. So having a day of the flu is, 0.13 units bad. Actively having a heart attack is, roughly triple as bad as that, between 0.4 and 0.5. Having moderate severity depression is about as bad as having a heart attack every day. And when I first saw the statistic, I was blown away. They measure these things in the same way they measure, flus and heart attacks and other sorts of illnesses, but this is a very serious degree of suffering. And the good news about a heart attack is usually you're not in that degree of pain and suffering day after day after day, whereas with depression, you are. Here is dying of cancer without treatment. One of the most horrific conditions that a person could imagine is those late stages of cancer, with cancer having eaten your body. And here is severe depression, even worse than late stage cancer. So in terms of how serious a thing major depression is, it is quite serious. It's also quite prevalent. And I pulled a number from 1952, 5%. Because it's been with us for a long time, at least back to the 50s. The number hasn't changed, or maybe it's a little bit higher now. Some people argue it's in the 7% range now. But it's not like we're doing something that this is something that's just coming about because of the internet or because of modern conditions. It's been with us. We've got classic descriptions, as in the book of Job, as well as going back to the 50s, using similar sorts of scales and definitions. Now, what exactly is it? And so there's a few perspectives, and I'm going to be starting with the neuroscience perspective. And so the neuroscience perspective, there is this region. This is called the cingulate cortex, or the anterior cingulate cortex. And it sort of wraps around in the middle of the brain. Right below this spot here, some people in the olden days thought this looked like a knee, and they called it the genu, so subgenuate cingulate, this spot right here. That is one of the most important spots for depression. It's hyperactive. It's a spot that would be active if I asked you to think about sad thoughts, but it gets sort of stuck in the on position. It gets hyperactivated in depression. And so this turns out to be one of our core treatment targets, is how do we deactivate that part of the brain? And so the other thing that happens is the rational thought part of the brain, the prefrontal cortex, and especially this section of it, the dorsolateral, is supposed to be in control of this. And they're supposed to be, when this one's on, this one's off, and when this one's on, this one's off. It's hard to be sad and do calculus at the same time. And that's by design. They get hyperlinked when you get depressed. So they're on at the same time. And it seems to be much more that this one, the subgenuate, is driving the prefrontal cortex rather than the other way around. And so these feelings of, the feelings of sadness driving everything, or the feelings of depression driving everything become key. The other thing that happens is in depression, the prefrontal cortex is supposed to be connected to all other parts of the brain pretty strongly, because it is, in fact, it's supposed to be the executive part of the brain. It's the one that's making the decisions. But in major depression, it gets disconnected. Those connections get lost, and it's almost like you have it pulling away and disconnected from the rest of the brain. And so this explains a lot of symptoms in depression. So this idea that I would like to get out of bed, but I can't. Well, the thought I would like to get out of bed is here. Moving my legs is over here in the motor cortex. So that itself is part of the brain that's being disconnected. So the ability to control the rest of the self is gone, or the rest of the body is gone, or is at least reduced. Now, it's not just about the brain. And this is one of the other things that's easy to miss or not appreciate with depression. Because in depression, it's also the immune system. So there are measurable differences in the actual immune system. So there's a bunch of different cells. We don't need to get into the details, but these are 4 different levels in the immune system of measures that are pretty reliably able to be monitored, but they're changed in people with depression. And so it's almost it's almost like it's not just the brain that's the problem. But the brain is definitely a problem. We get measurable differences there, but it's also a body problem. And here's another measure of the body being disordered. And it's not just that. Yes, it might start at the brain, but the stress hormone feedback system, sometimes called the HPA axis, is disordered. So the adrenal glands down here in the kidneys and some of the parts in the brain that control stress response are also measurably disrupted in people with depression. So again, this idea that it's all in your head, well, no, it's not. I mean, it's definitely in the head. That's a major node of where the problem is. But there are other very clear disruptions in human physiology. And so that's this is another example of that. Now, one other thing is heritability. One way we know is something a biological condition is to look at, can you get, are genes disrupted? Can you get this from your parents? And can you get this from your parents even if you don't grow up with your parents? And so this is a measure called heritability. The statistics are kind of hard. This measure, again, is not straightforwardly intuitive, but basically how much of the variance in the disease is explained by straight inheritance, that you got the, so for example, with eye color and height, eye color, if you have the right eye color genes, your eye color is going to be brown or blue. And it doesn't matter how much you try or how much you work at making your eye color different, there is no change. It doesn't matter if you are well-fed or poorly fed. If you got blue eyes, you got blue eyes. Height is about 80% heritable. There are some environmental conditions that can change your height, usually in the negative direction. So for example, poor nutrition or stress might reduce height. But look at other mental health conditions like schizophrenia. That's just about as heritable as height. And so what is even plausibly explainable by environmental conditions or choice is minimal. And it's less than 30%. So too with bipolar. Intelligence comes in around 60 or 70%. Alcohol is about half heritable. Violent criminality is also very highly heritable, as is lifetime income. But then when we get down to depression, anxiety, depression, and suicide, we're down in the 40% range. Now, what that means is that it's about half explicable by genetics, that just the pure biology that you have explains a lot about why some people are depressed and some people aren't. And that's not really changeable. Now, there's this, but then on the other side, there is this huge section that is potentially changeable. And that's the remainder is broken up between environmental concerns, in other words, things like childhood upbringing, as well as things like a person's choices or the sort of environment they have right now. And then, but then again, there are also other biological conditions like Parkinson's disease, which are very, that are not explicable almost at all by genes. And so, but we also don't understand environmentally very well where Parkinson's comes from. So all that to say, this is where depression is on the heritability scale. But it's also very much connected to childhood events. So for people who had, for example, a traumatic childhood, and traumatic can range from anything from straight physical abuse to having a caregiver who was in jail, or a parent who was in jail, or a parent with mental illness, or a parent with, so there's a whole variety of things that count as adverse childhood events. But if you have 4 of these, it changes a lot of these various risk factors, or these various conditions. So suicide has increased 1,200% if you've had more than 4 of these. Alcoholism by over 700%, drug abuse by over 400%, and depression over 400%. So a huge part of the depression that's in the world can be connected to things completely outside the control of a person with depression. Also interesting is that other biological conditions like heart disease and cancer are doubled in people who have these adverse events. And it seems like that is separate from any other risk factors for cancer and heart disease. So it just shows how tightly connected the body and brain are. And so for some things we like to think about physical illnesses like heart disease, yeah, having psychological trauma puts you more at risk. So too with depression, that it is something else that is responsive to these sorts of psychological traumas or difficulties. All right, we're going to go into some specific topics. Now, I've talked about sort of these things at a high level. What exactly is it that is the problem in depression? What are sort of some formal definitions and some of the biology? But how does this play out in a day-to-day life? One way it plays out in a day-to-day life is in talking about effort and energy. I think this is one of the most common fights or challenges or difficulties with being with a depressed loved one, is that the normal responsibilities, the normal activities that a person is expected to do, they're not keeping up with what they should be doing. And so I'm going to show you a model and describe how this works. And this is critical because praise and blame are all affected in this situation. And I think it's easy to fall into one of 2 opposite errors. Not having any expectations, saying, hey, this is all my biology, or this is all their biology, we just need to not do anything. And the other is saying, this is all your fault, you just need to try harder. So let me explain how I think this works for a normal person. Okay, so it's kind of a busy slide, but imagine you're a normal person and there is an amount, some tasks, you've got this amount of effortless energy and this amount of energy that if you really push yourself, you could get something done. So for most people, getting out of bed requires no energy. It's just something that you have enough energy to get out of bed without any having to push yourself. Now, sometimes, I'm not going to say anybody on this call has ever done this, but sometimes you have the energy to do something, but out of laziness, you choose not to do that. So imagine, have you ever been expected to, say, do the dishes, but you didn't, yet you could have if you really wanted to? Yes, we've all done this. And this is called laziness. We could do it. It would take a little bit of extra effort. It doesn't come automatically. Maybe we're having a hard day. Maybe our effort energy is low or changed. But like, we could do the dishes if we wanted to do the dishes. We just don't want to do the dishes. That's called laziness. Now, imagine a really hard day at work. You put in all your effortless energy. You have to work really hard to get through this hard day. And at the end of the day, you're beat because you used up all your energy. That's praiseworthy. That if you go and you do hard work for the sake of another person, say your family or your loved one, or for a good cause, that is something that is hard to do and should be praised. Now, for most of us, running an Ironman is impossible. The amount of energy, the amount of effort that it would take to run an Ironman is just simply out of our capacity. And so if we were, this is not either laziness nor praiseworthiness to run 3 miles and then be exhausted because, hey, we're out of shape. This is just simply impossible. This is just outside the bounds of praise or blame. This is just pure biology. My biology right now does not allow me to run an Ironman. And so one could blame me for not training to run an Ironman, but right now, today, it is impossible. And so it's outside this range of praise and blame. Okay, let's talk about a depressed person on a bad day. What does low energy mean? It means that the amount of effortless energy is almost nil, and everything is going to require effort to do. And so for a severely depressed person on a bad day, getting out of bed is simply impossible. That the amount of energy that they have, even if they use up all their energy, it just isn't going to happen, you know? And so, okay, let's go to this harder task, doing the dishes. Well, that's also definitely not going to happen. Putting in a hard day at work, that is definitely not going to happen. And so for a depressed person on a bad day, there is not much by way of praise or blame that one could do. There's just the biology has gotten to a point in some people on some days where there is no moral responsibility, or at least it's minimal. And at least in this the simplified example I'm showing with these 3 tasks, I would say there's nothing to blame in this particular person on this particular day. Now, the challenge of this whole situation is this. We don't know this, how much energy is available. Now, it could be that a depressed person on a decent day could get out of bed if they worked at it. Now, the interesting thing about this is that for a depressed person on a decent day, this is actually praiseworthy. That in the same way that it's praiseworthy to, say, do the dishes when you don't want to, it's praiseworthy for a depressed person to get out of bed. That's actually an accomplishment. And doing the dishes, that is as hard for a depressed person sometimes than it is for you or I to put in a hard day at work. That is a Herculean effort that should be praised. Now, imagine a depressed person who goes to work for 4 hours and then that's it, they're out of steam, they go home. It might have been that at this particular example, they could not have put in 8 hours, but they did put in 4 hours, and that is so much better than if they put in 0 hours. And so that is something in this example that could be praised. Now, the other trick here is that imagine an example where this is gone and the person doesn't get out of bed, but they're having a decent day. It's still possible, in my opinion, for a depressed person to be lazy. It's just really difficult for you or them to know, is this being lazy, or is this I simply don't have the energy? Because this exists. It is some days, and the trouble with depression is that some days this is the situation, some days that's a situation. And so this is a critical thing when communicating, and we're going to practice this later, is to appreciate that sometimes what you're asking the person to do just is not going to happen. But other times it could happen and they're choosing not to. And figuring out how do you deal with that as a couple or as a father and son or as a friend is really difficult. Okay, so for specific thing number 2, this is a casserole. Why am I showing you a casserole? Sometimes I've heard mental illness called the no casserole disease. If you get cancer, your friends will, people will bake you a casserole. If you break your leg, people will sign your cast. If you get depressed, you don't talk about it. Usually this is the kind of thing that is not talked about and does not bring people together to rally around the person who's sick. But as we saw, it can be worse than cancer in terms of the pain, the day-to-day pain and suffering and misery that the person is in. And so one of the specific issues I wanted to at least acknowledge was that this is a difficult thing to go through, because often couples are going through it alone, or a father and son, or many of these other examples are alone in their suffering. Here's another issue: sexuality. So oftentimes, one of the areas of loss is of libido, or desire for sex. And this is apart from anything that might be happening in past traumatic experiences. It's just simply the desire, enjoyment, thinking about sex is gone and low. And so this can be really difficult if you as a partner are say married to the person and not yourself depressed. It can feel like you personally or specifically are being rejected, or that the person doesn't care. But it is often the case that they do care. It's just their capacity to show it in this particular way is diminished. Here's another definition. I pulled this directly. One of my favorite $10 words is lassitude. Difficulties in starting simple routine activities which are carried out with effort. That is a description in one of the standard depression scales called the Madras of moderate depression. So sometimes I'll ask people about like personal hygiene, like have you showered today or this week? And oftentimes like, no, like that is so effortful for somebody with depression that it doesn't happen. So it can be difficult if you are an active person, if you like going outside the house and doing things, and your partner or friend or child is just laying in bed all day and not having the energy or desire to go outside. And again, it's doing your best. It's very difficult, but do your best to separate your personal sense of that this is not a personal attack. This is not something that is directly targeted at you. This is a situation that is happening to, this is a at least in very large part, biological condition that is affecting the partnership or the relationship. Here's another one. Inability to feel. This is also a quote from the Madras. This is for the severe symptom. The experience of being emotionally paralyzed. Inability to feel anger, grief, or pleasure, and a complete or even painful failure to feel for close relatives and friends. This is another one. So oftentimes, especially in the modern world, we almost define our relationships by how warmly we feel towards others or how people express that warmth. And so in somebody who has a, say, a commitment to another person in a marriage, or who is supposed to love their mother, that's not necessarily going to be possible in some stages of depression on the emotional level. And so my advice here is recognizing that relationships are more than, the connection is not purely emotional, that the connection is sometimes a commitment, sometimes an oath, a marital vow. Sometimes it's a history that you have. So remembering that relationships are more than just the emotions and the feelings that you have in them. And last, the last specific issue is suicidal thoughts. And this can be range anything from I wish I was dead or hoping for a disease to come and take them, to actively planning suicide. And this can be incredibly painful for a loved one, because the feeling might be, aren't I enough? Like, don't you want to live for my sake? And the answer is, it's fascinating and disturbing, but the answer often is that they can't see you as an emotional being. The capacities to imagine how you would respond are broken. I remember talking to one person about their suicidal thoughts, and she imagined her mother walking in on her deceased, on her having killed herself. And she imagines the first thought her mother has is, oh my gosh, how will I clean up this mess? And it's just not like, oh my gosh, that's my beloved daughter, or why would you do such a thing? But the emotional connection that that bi-directional emotional connection that we all normally feel is broken. And so even the capacity to imagine what a person would be feeling in that situation is gone. It's almost like a type of blindness. But again, not to take this personally, and especially with suicidal thoughts, to make sure that the person is getting professional care if they have these thoughts. So moving on to treatments. I'm going to talk briefly about treatments because it's not necessarily your job to, it's not your job to prescribe treatments for your spouse, but it is your job to encourage them to continue to seek care and to take the next steps on the pathway. And so what's the pathway? 1957, we came up with our first antidepressant medication. 1986, we developed SSRIs, which are safe and effective and easily available to most people. From a medication standpoint, if a person remains depressed, try another medication. And that's the sort of evidence-based guidelines. And if their doctor is not getting them the next medication, you can encourage them to push on their doctor or find another doctor who's willing to go through these different medications or different kinds of treatments. Sticking on one is usually not the right idea if the symptoms remain. So this has been a widely adopted approach. As of 2012, roughly 9% of Americans were on antidepressants. There's also therapy. These two are guys that developed a popular kind of therapy called cognitive behavioral therapy, Aaron Beck and David Burns, and making sure that your loved one is in therapy if they're continuing to have symptoms. There's new stuff that I'm super excited about, called TMS, a non-invasive brain stimulation method that is also incredibly effective against depression and extremely exciting. So I'm just going to describe a treatment plan, but the key of this treatment plan is making changes quickly so the person gets out of depression. Okay, so here we are, assuming 100% of a population that started out 100% depressed. We give them psychotherapy. About a third of people will get into remission. About a third of people will have a response. That means a 50% improvement. About a third of people won't budge. We start a medication. Again, we get this movement. More people, now over 50% of people with medication might be in this response category or this remission category. Over 90% of people will have some kind of improvement. Then let's try another few medications. Each one of these might take a month or two, but still, we're making progress. We're chipping away at that black bar at the top of people who remain continuously depressed. But then let's give them TMS. We get another boost. And then a new thing we're doing is accelerated TMS. And look, almost nearly everybody at the end of this course of care is going to at least experience a period where the depression lifts. And so the idea that I want to communicate is that there's hope, and that things are likely to continue to get better.